So my topic today is respiratory distress in newborn. You dah belajar ni? Your last group
Yes.
That's your 5 group. So the key here is that one is newborn, another one is the respiratory distress. So we're talking about newborn, I mean that just been born. Talking about neonate, I mean that less than 4 weeks. Between 0 to 4 weeks of life. We're talking about the infant will be less than 1 year, 0 to 1 year of life. That's what you mean by that. Newborn just been born. Respiratory distress, I think you all know lah. Difficulty in breathing. So your level is more of the identifying and then to recognize the cause. So the cause of respiratory distress in newborn can be from respiratory system, mainly the respiratory system is the main system involved, cardiovascular, central nervous system, musculoskeletal and metabolic problem. Many causes. But I can say to you from my experience, 90% from respiratory system, even 90%, 95% from respiratory system. Occasionally we do see due to other causes. You look at for respiratory system mainly, for airway obstructions, the disorder of the chest wall and diaphragm, malformation of mediastinum and lung parenchyma, air leak syndrome. For airway obstruction, nasal stenosis, tonal atresia, so many things. On the airway here, upper airway until the lower airway. Whereas from the wall can be hernia, and then for chest wall deformity, lung parenchyma can be some congenital lesions. Air leak syndrome can be air inside the lung, water inside the lung. Pulmonary parenchyma and vascular disease can be this more common. TTN, meconium, highly membrane disease or respiratory distress syndrome, pneumonia, congenital vascular is rare, edema. And then the other condition that fairly common is cardiac disease, which is the cyanotic or acyanotic. Then these are rare, neurological, from birth trauma, intravascular hemorrhage, meningitis, disorder of the brain, seizures, and other sepsis. This is quite common, but usually related with the pneumonia, anemia, polycythemia, and the rest. So what are the signs? The sign can be divided into the mild, moderate, and severe. Mild patient can have tachypnea, tachycardia only. Moderate can be some evidence of subcostal sessions, nasal flare. Severe can be sinus, gangrene, drowsy, or comatose. Very looking. So that is how you differentiate. Is it mild, moderate, or severe? Other signs you can looking at is poor or intolerant feeding, inactive, poor perfusion, hemodynamically not unstable. I mean that the BP, pulse rate, heart rate, all is not in normal, and then stridor, wheeze, listless, and temperature instability. Sometimes they are mainly hypothermia, sometimes they become also hypothermia. Treatment wise, always when it comes to this, go to the AC. Airway, breathing, and circulation. Secure the airway first, suction, positioning, bag, mask, intubation, blood pressure and perfusions, and treatment the specific cause. After you settle this one, secure the airway, breathing, and circulation, then only you go to the treatment the specific causes. This is example, but it's not a good way to do because they do it on the picture. You do proper CPR not on the patient only, but you have to know how to do the technique of CPR. So understanding, in order to you to be able to understand the disease and the treatment, first you have to understand the and some bit about anatomy. Look at the nasal cavity, pharynx, epiglottis, larynx. This is the bronchus, lung, diaphragm, pleura. This is the anatomy of the respiratory system, and so the bronchioles and the alveolar sac. This is the anatomy. Understand the anatomy. Any damage of this region can cause the respiratory distress. And then understanding little bit about their respiratory development. The embryonic phase, pseudoglandular phase, canalicular phase, alveolar phase. Then at this age is where they are intrauterine, and then the alveolar mean when they delivered, when the baby was born to the age of 8 years, and when they reach adulthood, the size and diameter of the airway and the respiratory system are increasing. And then there is the phase, embryonic phase and fetal phase. For embryonic, pseudoglandular, canalicular, saccular, you can see the development in anatomic. And anatomical development from bronchioles, terminal bronchioles, respiratory bronchiole, alveolar duct, and alveolar sac. And here, where the very important aspect is development of organs and differentiation. And you look here where the surfactant been produced intrauterine. Surfactant start at the age of 24 weeks above, mean 26 where they be detected, but sometimes at 25th week. You can see. The surfactants needed for expansion of airspace, and there where the development, and there is the birth. So you can see the organogenesis, and then the differentiation, the differentiation of the respiratory system. So let's go one by one. Respiratory distress syndrome, Highland membrane disease. This is due to surfactant deficiency, mainly the phospholipid. The function, very important to understand the function of surfactant to prevent the airway from collapse. What the risk factor of having RDS, prematurity, male sex, perinatal asphyxia, maternal diabetes, antepartum hemorrhage, cesarean section. And X-ray help to make diagnosis, and management usually respiratory support, fluid electrolytes, acid-base balance, antenatal steroid surfactant replacement. This is the role of primary surfactant. So surfactant is also, that surfactant is necessary all over at your lifespans, not only in unit or during the newborn. There are many conditions where the injury of surfactant can cause respiratory distress in adult and in bigger children. So the function of surfactant is to increase pulmonary compliance, meaning reduce the effort needed to expand the lung and reduce the tendency for the airway collapse. This is surfactant, the alveoli, produced by the type 2 cell. They produce type 2 cell, produce the surfactant. This is alveoli. So example, you ducts, alveoli, and type 2 cell where surfactant being produced. And then how it works, that it works at the interface between the air and the fluid in the alveoli. The interface, it causes, we call it increase the membrane, because a small membrane here, the surface, so it increase the surface tension of the fluid, water. So result prevent the collapse of the alveoli. And what happens if alveoli collapse? It become like this, solid, like liver, without any air space inside it. And then when you do the X-ray, this is the main finding, solid lung, small granulites, lesions. With on this type theory, you just can see only the air, bronchogram. The lung is solid, that the picture here. So imagine, so if the lung is solid like that, definitely the child unable to absorb the oxygen, and then because generalized hypoxia. There are many types. There are severe one, there are mild and moderate, and the mild one probably just a little bit only. The moderate one is a bit more deeper, and there is severe one. Then usually if the severe one, you need the mechanical ventilation. And then, but the treatment now we have is to give the artificial surfactant. There are many types of artificial surfactant. One of these Surventa, artificial surfactants. So the other one is the congenital pneumonia. Congenital pneumonia, by the definition, you know, is pneumonia. Congenital means that they have it intrauterine. That means congenital pneumonia, not extrauterine. The common organism is group B, Streptococcus. The other are Listeria, Klebsiella. The risk factor is maternal fever, infections, or mother having UTI, or inflammation of the chorion and amnion fluid with chorioamnionitis, premature rupture of membrane, prematurity, colonization of the tract, the delivery tract by group B strep. Treatment, of course, the main treatment is antibiotic plus the support of respiratory distress. And then the transmission can be hematogenous, ascending, or aspiration. The sign and symptom you can look is elevated respiratory rate, tachypnea, retraction of the respiratory wall, intercostal resection, and then grunting, nasal flaring, increase of mucus and other fluid with substance in the airways, unstable body temperature, poor feeding, abdominal distension, jaundice at birth, glucose intolerance, hypoperfusion, even sometimes they have oliguriah and cyanosis, because of the inability to lung to function normally, result in the hypoxic. And then example, result in the inflammation of the chorion and the amniotic fluid. The X-ray a bit more softer, not solid like the first X-ray from RDS. A bit more softer. The some doesn't look like. You can look here is a typical pneumonia X-ray. A bit more softer. Like the first one is solid like. And then the other one is transient tachypnea of neonatal unit, TTN. This can occur 1 to 2% of the causes of respiratory distress in children, in newborn, usually in large preterm or postterm baby. The pathophysiology is because you see intrauterine, the lung consists of fluid. Lung consists mainly the fluid, amniotic fluid. So in the delivery, there are mechanisms where the lung become clear from the fluid, so function immediately in its extrauterine. I mean, function mainly to absorb the oxygen and then to absorb and then to repel the carbon dioxide. So the retention of this fluid impaired the function of the lung extrauterine. Then the impairment of this result in that the child is hypoxic and need develop sign and symptom of respiratory distress. I think you also same like the other sign of respiratory distress, tachypnea, tachycardia, intercostal recession, subcostal recession, grunting, and cyanosis, and very ill looking. Can depend very mild to severe. But one thing about TTN, it rarely persists more 48 hours. Usually after 40 hours, majority, even almost all the lung, almost all in babies, the lung will be dry out. In either way, I mean that the body absorb the residual of the lung from the lung. And the other thing, the main risk factor is cesarean section, because cesarean section, you know, first when they go into a uterine canal, they will squeeze, the fluid will be squeezed, and when they come out, the child will cry. They cry in such a way that it push the fluid force the fluid into the blood, interstitial fluid, interstitial tissue, clear out the alveoli. So cesarean section is because the baby didn't go through the birth canal. They come out immediately. Sometimes baby cry, sometimes baby still sedated due to because of the using of the anesthetist medication, and then the lung unable to dry properly, result in the retain of some fluid, and this fluid affect the part of the physiology of the lung function, and the child, baby, or the newborn develop respiratory distress. Yeah? The X-ray is very clear, can have distinct feature. You can see the air bronchogram, the air fluid between the fissure. The one is another one here, but here the main thing, the main is the fluid in the fissure, which tell you that there is a fluid into the lung. The other one is here. Meconium expression syndrome is another one, which is fair country. What is a meconium? Meconium consists of fetal GIT secretions, epithelial cells, and hair that swallow that the things that inside their GIT tract. That is meconium. And meconium, what happens is that during the certain because of certain stressor, the baby pass intrauterine into the amniotic fluid, and this meconium is quite toxic and very sticky. This can cause obstruction and pneumonitis. The risk factor mainly the postterm and asphyxia. I mean, when child asphyxia, it pass meconium intrauterine. The future will be the fluid, the amniotic fluid have meconium, the meconium stain on the body, and then the evidence of respiratory distress. The child got tachypnea, tachycardia, subcostal recession, grunting, flaring. The treatment is more to prevent the child develop hypoxic, intrauterine, and then when there is evidence of fluid inside the evidence of meconium inside the amniotic fluid, you have to suck the patient, the baby, properly during delivery. You can look the meconium, very sticky things. Very sticky and sticky. Imagine this one enter into the airway of the baby, of the newborn, and into the lung of the newborn. It block. And then in the lung it cause a damage. And there is pathophysiology. Actually, it's more complex than just a blockage. So it involves also the chemicals, the surfactants, destruction of surfactants, leaking of the proteins, pulmonary vasoconstrictions, intrauterine hypoxia, airway obstruction, and so on. So the X-ray is big difference. You got hyperinflated. The X-ray should hyperinflated lung field with some whitish infiltrate. We show you the meconium that block the airway and cause the damage to the parenchyma. Others like pneumothorax, pleural effusion, hemorrhage, congenital anomalies, hypoplasia, sequestration, congenital diaphragmatic hernia, and so on. Anybody can think what of this?
Congenital diaphragmatic hernia.
Which part of the hernia?
The left side. There's presence of the bowel.
Bowel in the left side of the lung cavity, thorax cavity. Sorry, there is the lung which is compressed, abnormal. The heart and mediastinum shifted to the right side, and you can see there is also a compress of the lung. So this is the postmortem of the baby to die because diaphragmatic hernia, left diaphragmatic hernia. You can see here because the absence of the pleuroperitoneal membrane result in the herniation. Result you see the colon, GIT tracts, stomach enter into the thoracic cavity. If the X-ray can show nicely the air of the GIT tracts. Here. And the lung is solid. Here only the lung got some expansion. Is sometimes they just little bit only. And they come. We have case who came to see us when the patient is adult. They noted that recurrent pneumonia all got because of GIT tract become bigger, intestine compression, and develop this gangrenous region. Then they only came to see us. Anybody can figure out what is this?
Tension pneumothorax.
You can see the air inside the lung cavity. Thoracic cavity push the heart to the left side, compress the right lung. This is a severe pneumothorax. This one, anybody?
Congenital lobar emphysema.
You can see here. X-ray, you can see something very long here, very quite darker compared to other side of the lung field. Is it pneumothorax or is it we don't know what is that. We do the CT, noted that there's some lung tissue still, but the lung, the alveoli is very big. There are a lot of air inside here. And usually this one dysfunction, not functioning, and what happens is that it suppress the right lung, the lung parenchyma, the upper lobe, and then the lower lobe here. So, and then push the mediastinum to the left side. The treatment only is you excise this. Once you excise this, then the expansion of the normal lung will happen. The child will recover. This one.
Mass on the left side of the lung.
You can see there is a very big mass here. They compress the lung. This is mediastinal bronchial mass, bronchiosis we call it. From here we know it consists of mainly fluid. Congenital lesion. The child coming at birth with respiratory distress. This one?
Hypoplasia.
You see the lung field very small. Compare, you see this is the chest X-ray. Yeah, the lung very small. Very small. This is the liver until here. So it is a bilateral hypoplastic lung. See, this is the X-ray. When you do the postmortem, the lung are very small. Postmortem. The other thing is airway abnormality. There are many types of airway abnormality. Airway abnormality can be from stenosis, myelactic. Myelactic means that very soft, collapse just like that. Very soft, unable to sustain the shape. That one tracheoesophageal fistula. I mean that there is a fistula between the tracheal and then esophageal. This is type of fistula. You can look example. The most common is the laryngomalacia, which is the epiglottis are very soft, collapse by itself. They can come with a stridor. Stenosis is another one. Look at stenosis. Stenosis can occur everywhere. From the trachea, can be bronchioles, stenosis. Wait, ada lagi. The thing is respiratory distress syndrome due to cardiac. The cardiac can be a heart disease, cardiac cardiomyopathy, PF, persistent fetal circulation. They come with cardiac failure. If certain condition result in pulmonary edema, lung is full with fluid and unable to function properly. The other one is PFC, persistent fetal circulation, which is what it means is that the fetal circulation, the physiology of fetal circulation didn't change, because in fetal circulation, intrauterine, they work different from the baby, newborn circulation extrauterine. When become persistent, persistence result in they are unable to absorb the oxygen from the air in the lung, and the child develop severe hypoxia and respiratory distress. Because in persistent circulation, the right side of the lung is higher pressure than the systemic. But whereas in the extrauterine circulation, newborn and like us, the systemic circulation is higher pressure than the pulmonary circulation. So as a result of that, there is the circulation cannot mix together, and then the oxygen cannot be absorbed from the lung, from the air from the lung, and the child develops and if you cannot retain, if you cannot open up to mix this circulation, then usually baby going to die. What we do is that we try to give something to open up the ductus, the ductus arteriosus, so that the circulation can be mixed, and the baby can survive. The other rare one is a muscle problem. You need muscle, spinal muscular atrophy, type 1. There are many types of the muscular disorder, muscular myopathy, and depend on severity. But the one that usually you saw early in the life is SMA type 1, which is not able to move at all for respiration. I mean, no point you have the brain, you have the nerve which give the signal, but the muscle unable to work. And then there are patients who not much we can do. Usually type 1, that SMA type 1, not much you can do, because it is the problem of muscles, unless you replace the total muscle, which is which we cannot do so much about it, because it's born with the muscles abnormal. So go back to the treatment wise, always assess what you do, the immediate management. You give the ventilation support, A, B, C, and you treat the causes. Let's say the causes is sepsis, you result in metabolic acidosis, and you treat the sepsis. If the treatment is due to respiratory problem, like highly membrane disease or respiratory distress syndrome, you support the baby, and then you give the surfactants. If due to TTN, you support the baby, and after 40 hours you can stop everything because the lung is already clear from the fluid. So it depends to the causes. You treat accordingly. But there are things that not much we can do, like the muscular SMA type 1, in which we don't, if it's type 1, not much we can do, because the muscles is so defective that unless you have a procedure to replace all the muscles in the body, only then you can save the baby. Usually at that time of case, we talk to the parents. We say that we're going to accept the inevitable, and we accept the baby to let go of the baby. Okay, any questions?
Dato, I have a question. My voice clear kan? My voice clear tak? Okay.
Ada lah, dengar lah tu. Okay .
So if let's say we have a patient yang ada MAS waktu dia kecil, and then they survive, Tapi dia develop PPH lah, maksudnya PPH secondary to MAS kan.
Hmm.
Is there any long term effect
There
for
are
this?
depend how bad the damage to the lung. If the damage is a lot, they can have a residual damage. They affect the lung function for the time being. Sometimes it go for 1 year, 2 years, other 3 years, other 4 years. Because the lung has been damaged, cannot been cured. It had to be replaced with the new tissue. That's all. So it takes time. But there are many cases that, though how bad how severe is it, because the treatment is, and then the treatment is prompted, and then not much complication, the lung is not bad damaged. Sometimes the baby can get out with very little effect. So we wouldn't know until we go step by step, see how it goes. But by right, the one indicator is that how long you need to ventilate the child. If you need to ventilate the baby for long, 2 weeks, 1 month, usually is indicator of very bad lung damage. Okay, anything else?
I have a question for newborn with respiratory distress syndrome. So the definitive treatment is that we give surfactant, but how long do we have to give the surfactant?
It depends how bad is it. There are patient baby who need just 1 dose. There are baby who need the 3 dose. Their baby needs 6 dose, 2 days. Usually, but it doesn't take so long because after a few 40 hours, the body has their own surfactant. But depend how bad is it. Many patients need just 2 dose, 3 dose only, and then after the body will produce their own surfactant, and then you get to surfactant. There are cases only 1 dose only. Just give 1 dose is okay already. Because the surfactant deficiency can be, it can be 100% deficiency, it can be a 50% deficiency, it can be 80% deficiency. Sometimes you give a 1 top up already for 1 dose, then the lung already able to function properly. Okay, anything else? Generally, the more premature the baby, the longer they need. Usually, if they are 24 weeker or those or 18 weeker, so 18 weeker usually need more surfactant compared to 24 weeker. Because 24 weeker, their cells already prepared to produce their own surfactant. Okay, any other questions? Okay, I just wonder, you all, where you all now?
Some of us are at Mahala, but like most
So
of us.
how long the teaching going to be? You know, some of you there, some of you here. How the teaching going to be? Some of you, those who going to be in campus, they will have face to face, is it?
Yes.
Yes.
So that's their advantage. What happened to why you cannot come back? Those in at home.
I think because mainly of the PKP restrictions, we still cannot cross the border, especially those from.
See, I don't know what's happening, you know. That's why I must say at the beginning, when I heard so many year 5 not going back, I'm very happy. I think it solved the problem of being as a team, you know. Then I heard some going back, some not going back, and so on. I got, it's going to be a problem, and that's what happened now. Let's see if you're not going back at all. Yeah, don't you think that it was solve many problems? That's why when I heard, Because I surprised year 3 majority able to be here now. Why the majority year 3 able to be here? Well, year 5, the one that going to be more important year, they are so divided. Somewhere here, somewhere there. I don't wonder what the advice was given to you all. Now year 3, the one that more of them are here and at home. I don't know. Sometimes I still wonder why you all want to go back. Just another year to sort out, and then after that you can take a long leave, 8-month-year leave. You know, after this you will stay at least 1 year at home. Just a matter of, you see people yang overseas ni cuma 3 tahun tak balik, they don't bother at all. No problem. No, some of you got some here, a few of you is there, so we don't know how to arrange the teaching because so mixed out. Okay, finish. Okay.
Thank you.
Dah left eh?
Dah left. Boleh left.
Alright.
Okay, bye.
So thank you everyone. Bye.
Thank you.